if we were to treat patients for a longer period of time than we've been able to treat them so far, we'd begin to see these disease-modifying effects and biomarkers and such.
Gabriel, thanks so much for taking the time to have this conversation. I so appreciate you coming over to report.
My pleasure.
For the audience at home, welcome to Power to the Patients. My name is Brandon. Today, I'm excited to welcome Dr. Gabriel Vargas, a physician scientist, chief medical officer over at CuraSen. You have extensive experience in early drug development with a focus on neurology and psychiatry. So today, we're going to jump into all that kind of work. And maybe I'll give you an opportunity just to introduce yourself.
Sure. My name is Gabriel Vargas. I'm the chief medical officer at CuraSen. I've been with CuraSen for about 7 years, basically since the very start of that company. I've been in industry about 20 years, mainly working on neurology and psychiatry during that space, and particularly with neurodegenerative disorders, Alzheimer's disease and Parkinson's disease. And currently our focus at CuraSen is in the adrenergic system. I think we'll talk about that a little bit later.
Absolutely. Before we dive into the science, what drew you to psychiatry, neuroscience, drug development? I'm sure your career could have gone many different ways.
Absolutely. I think careers can go a multitude of different ways, and a lot of it is serendipity, and you happen to be at the right place at the right time, and you meet the right people. For me, I was drawn to science originally because my father was a scientist. He was a physiologist, biophysicist, academic, worked for many years at the university. So from very early on, I was very interested in science. And then when I arrived in Berkeley as an undergraduate, I was interested in kind of nature nurture. E.O. Wilson's Sociobiology had been published in the mid-'70s. It was a major book talking about the biological basis of behavior. I was very interested in that. So my undergraduate focus at Berkeley was anthropology and genetics. I was very interested in that discussion. Is it nature, is it nurture that forms us, when in reality it's really a mix of both, and sometimes a little more nature and sometimes more nurture. But that kind of tracked me into behavior and the biology, the genetics part. I was fascinated with biology, and that led to just an interest in biology in general, and with that came an interest in kind of fundamental coursework, if you will, in medicine. I was also working with the disabled student community at Berkeley, which is very extensive. And that got me interested in neurological disorders, spinal cord lesions, and the like. So I became very interested in pursuing a degree and becoming a physician scientist with the idea of doing a MD PhD program. So I ended up at UC Irvine in their medical sciences training program, doing a dual degree. So it's a combined program in which you do medical school and a PhD within hopefully 5 to 7 to 9 years, or in that range. Usually, an MD is 4 years, and a PhD is anywhere between 5 and 7 years. So for me, it was a 9-year process to get both degrees. And during that time, I worked in a signal transduction lab, so I was very interested in receptors, molecular pharmacology, and I also led the medical science training program lecture series for a year. And in that, within that context, I had the opportunity to invite Stephen Hyman, who at the time was provost at Harvard, and he's a very well-known molecular psychiatrist. That's how he characterizes himself. And I had lunch with him, and in over 2 hours, he convinced me that psychiatry was really the way to go, that we really needed people who did molecular work in psychiatry.
Sure, yeah.
So I was really inspired by that, and then I had the opportunity to attend several meetings for the American College of Neuropsychopharmacology, which brings together kind of the research psychiatry specialists from all over the world. So those are very exciting meetings. So at the end of my MD PhD training, I opted for a residency training program in psychiatry. Ended up at UC San Francisco in the research track. It was a very strong program, and they allow you to start research essentially second, third year of the residency program. And then I did that, and then graduated from that program. Did a postdoctoral fellowship with Mark von Zastrow, who is a MD PhD psychiatrist at UCSF, interested in how molecules move from the cell surface into the inside of the cell, so membrane trafficking. because that's very important for disease process. And also, I was interested in how drugs, and particularly antipsychotics, worked. And I was thinking that remember the binding dopamine receptors and the internalization of the dopamine receptors and then recycling back to the cell surface or degradation is something relevant to how we treat schizophrenia, for example.
Yeah.
So I did that basic science, and I also did a clinical fellowship. Sofia Vinogradov, who's currently the chair of psychiatry at the University of Minnesota. So very interested in schizophrenia in general, kind of the molecular pathophysiology of that disorder, which is fascinating, and also treating patients is very rewarding to be a clinician, to be able to treat patients. I think that is the beauty, I would say, of doing a combined degree program where you have both the basic science and the clinical work now that together, ideally, where you can do research and from the basic science perspective and apply it to clinical population. And that was kind of my perspective, and that's what I wanted to do.
Yeah.
So I received funding from NIH, the NIMH in particular, to continue research in academia at UC San Francisco with a K Award, which is an award for early investigators with a mentor. And so I was at UCSF an additional 3 years doing that. And then industry came calling. I was recruited at their industry. And I was very interested in kind of the translation. How do you apply kind of basic science into clinical work? And I thought industry provided a lot of the opportunity to do that kind of translational work. So I ended up at Roche Palo Alto. Which wasn't a really big change as far as location. I didn't have to move.
Yeah.
My commute, instead of going north, I went south.
Yeah.
My department chair was very accommodating, and I told him, I'm not sure I'm going to like this or not. Can you freeze my grants and leave my position open for 6 months, and then I'll figure out whether I like it or not. And then it was clear I loved the opportunity to work in industry and really enjoyed it. So I was with Roche Palo Alto for 2 years working in translational medicine, which is basically, how do you bring the knowledge you have in the preclinical world into the clinical world, especially in the early development space, phase 1 activities, where when you first bring a drug into the clinical, into humans.
Yeah. And I know one of the things, as we were kind of prepping for this, that you're excited to talk about is the idea of translational medicine.
Yeah.
Maybe let's even just start with
Sure.
What is translational medicine?
I think there are a lot of different definitions that I've come across. For me, it's really, it just hinges on the translational aspect of it. It's how do you translate the work that you've done in the preclinical world to first time in human clinical program. So prior to entering a human study, prior to a drug being administered to any humans, you have to do 3 general pieces of work, if you will. So you have to do toxicology. So you have to take that compound and examine different species, make sure that it is safe and understand the toxicology associated with it. Develop a means of the chemistry of the compound. If it's a small molecule, how do you make it? How do you measure? How do you make sure that it's pure? And look at potential metabolites, pharmacokinetics, and all that, sort of, so you understand the chemistry of the compound. If you're working with a small molecule, you could also be working with a larger molecule antibody, and that process is slightly different, but it's still the same thing. You have to do toxicology. And also understand how you make the compound and how you measure the compound. Yeah, you make sure that the compound you're making is really what you think you're making.
Yeah.
And then the third aspect of that is the clinical development program. What are you trying to accomplish? What are you going to do in your first time in human? So those 3 components are part of what is sent to a regulatory agency, such as the FDA, which is an investigational new drug application, or IND. So an IND the main components are the chemistry part, which is basically with the chemistry manufacturing controls is what is called CMC. And that encompasses, making the compound, making sure you're making the right compound, making sure you can measure it, understanding the potential metabolites, pharmacokinetics. Then you have the toxicology package, and you've looked at different species, have understood where the margins are. And by margins, I mean at what point do you have safety? You begin to see some adverse events at a certain exposure, and you want a margin much below that, so you can go into humans with that. And then lastly is clinical development program. So you let the FDA know what it is you're developing the drug for, what is the indication, which patient population, what your phase 1 study is going to be like. So phase 1 study is the first study in which a drug is tested in humans. Is otherwise known as a first in human,
Sure. Yeah.
or FIH study. It used to be called first in man, but that's
Sure.
sexist. So
No longer it.
we don't, because they do have women participating in these studies. So first in human or FIH study is really what we're talking about. And what are the goals of an FIH study? Is basically the major goal is safety and tolerability. You want to understand, is the drug that you're looking at safe and well tolerated? So safety refers to any adverse event that can put a patient in a dangerous situation.
Yeah.
Cardiac issues or respiratory issues, whatever. Tolerability refers more to, you have things that make it difficult for you to dose the drug. Do you vomit after taking it? Do you get diarrhea? Things like that.
And maybe this is a good jumping off point to talk about CuraSen.
Yeah.
Where are you in the journey here on CuraSen?
Yeah, so CuraSen has been in existence for the last 7 years. As I mentioned, our focus is the adrenergic system. So we're developing molecules of small molecules that target the adrenergic system. So let me explain a little bit of what I mean by the adrenergic system. So the adrenergic system is an essential, fundamental physiological system that does a lot of different functions. And you get from your biology, I'm sure you remember the fight or flight response, and that's really driven by the adrenergic system. So then when you see something scary, when you're out in the woods and you see a mountain lion, that sets forth a rush of the noradrenaline in the body that triggers the adrenergic component. And so what it does in the periphery, it makes your heart beat faster, so you get more blood. It releases glucose, so you have more energy. But interestingly, in the brain, it does several things that are very helpful for neurodegenerative disorders.
Interesting.
So the adrenergic system in the brain, so noradrenaline release improves attention. So, and you can understand why that would be important in the situation in which we're facing. That's right. You want to be attentive to that.
Sure.
And because of the threat component associated with it, you remember much better.
Right.
So this is work that goes back about 40 years, as James McGaugh, who is a researcher actually by MD PhD alma mater in this here. He published extensively on the effect that the beta blockers and beta agonists have on memory. So he would basically scare people, and by scaring people, they would remember events much more clearly. If you don't.
Interesting.
It's actually one of the most vivid medical school lectures I ever had. Was James McGaugh was a professor, and he was talking about memory. And in the middle of the lecture, he grabs a very, very heavy textbook. He raises it up and throws it with all his might the floor, and everybody's startled. And he said, "You're going to remember this lecture for the next 50 years."
Right.
And then, that lecture was about 30 years ago, and I still remember it because that response sets off your adrenergic system, allows you to remember it, and it gives valence to the memory. So valence is really basically like having a highlight on that memory. And it's triggered by the adrenergic system being stimulated and saying, this memory is important for you. It's something that you need to remember. And it came from survival. So it's very important for you to remember. So what we're trying to do is develop adrenergic agents that help with memory, that help with attention. And also the adrenergic system is important for mood. So if you look at antidepressants, a lot of antidepressants actually have a component that's neuroadrenergic. So the neuroadrenergic reuptake inhibitors, for example, drugs like atomoxetine, work through partially through this mechanism of action. Tricyclic antidepressants also have a noradrenergic component to it. So it's very important in the mood aspect of it. There's also been research. This was done in the 80s and in the Salpêtrière in Paris, in which salbutamol, which is otherwise known as albuterol, which in the U.S. is used as an inhaler for asthma. So beta 2 agonists, one of the things they do is they basically dilate your lungs so you can breathe better. So this was studied in France in the 1980s as an antidepressant using an IV salbutamol. Was shown that it was very fast acting. It was very efficacious.
Interesting. So it sounds like you're thinking about the adrenergic agents as applied to both neurodegenerative as well as psychiatric applications. Maybe talk to me about like where do you even start, or like how do you think about prioritization? That's such a wide range.
Yeah, that's a good question. I mean, as a clinician and as a researcher and as a member of the team at CuraSen, we think about that there are multiple different areas of focus, if you will, of how you decide which indication to pursue. One to me comes from a patient perspective, and the indication is unmet medical need. Where do we develop drugs in which we have a need for those medications? I spent 8 years at Amgen, and there it was very clear the Amgen focus is we do not develop me too drugs.
Yeah.
And by that, I mean drugs that are slightly different than the previous version of it. You've seen that with SSRIs for depression, but multiple SSRIs, and a lot of them are Me Too drugs that have maybe one component of it that is better than what was there before. But we don't want to develop Me Too drugs. We want to develop drugs that are fundamentally better for whatever aspect you're trying to improve. So that's the unmet medical need. Then there's a component, what's important to patients, what are they interested in as far as the disease. In neurology, in neurodegenerative space, you have problems with memory. That's the hallmark of Alzheimer's disease. You have a fundamental deficit in memory.
And so there's clearly unmet medical needs across psychiatry and neurology, right? I mean, we've had a lot of the folks on the show talk about some of the classic kind of like mood disorders, the challenges with traditional antidepressants, and anxiety kinds of conditions. We've had folks talk about schizophrenia as well. I'm kind of curious as you kind of scan here. I'm curious, what do you see as the primary unmet medical need that targeting the adrenergic system does better than the other kind of candidate therapies that are currently in research?
Yeah, that's a good question. I think, so let me give you a little bit more of a perspective on how we're targeting this. So as I was mentioning earlier, if you take a adrenergic agent, and the ones we've been focusing are two types. So there are 9 different receptors for the adrenergic system. 2 of them are particularly efficacious, and so beta 2 adrenergic receptor, which is helpful in asthma. So all the inhalers, albuterol inhalers, are worked through the beta 2 adrenergic receptor, and the alpha 1 adrenergic receptor. And I'll talk about those 2 separate. So the beta 2. So if you get somebody an oral beta 2 agonist, clenbuterol is a good example. Clenbuterol is approved in Europe and Germany in particular for reactive airways disease. So asthma, like in which your bronchi constrict. So a beta 2 agonist will relax the bronchi and allow you to breathe. So if you get somebody a beta 2 agonist, that helps their asthma symptoms, but you can also, if you give it systemically, clenbuterol is an oral agent. So if you get systemic, you also get an increase in heart rate. You can get palpitations, you can get tremor, you get glucose release, you get a drop in potassium. So a lot of peripheral effects that you don't want if you're developing a drug that is targeting the CNS. So what we have done at CuraSen is we've coupled our beta-2 agonists with a peripherally restricted beta blocker, NADOL. So NADOL does not get in the brain, and so you can co-dose them so that you add the clenbuterol and the NADOL together. So the NADOL blocks all the peripheral effects of clenbuterol. So you don't get the increase in heart rate, you don't get the increase in glucose, you don't get the drop in potassium, and that allows you to target the brain. So that's the way we're thinking about the use of beta-2 agonists. So we're using clenbuterol, which has been in the market for about 40 years, but we're also developing our novel chemical agents as well, also coupled with NADOL. And the idea is to develop a fixed dose formulation for those compounds. So you give a single tablet, and that has both the beta blocker and the beta-2 agonist. So it selectively targets the brain. Okay, so once you've developed that, what are the indications that would be helpful? So as I was mentioning, because of the essential fundamental importance of the adrenergic system and originals of fight or flight and all the things that come along with it, attention, memory, but also things like apathy and impulsivity are very relevant to the adrenergic system. So disorders that have issues with depression, cognition, arousal, apathy, impulsivity. So you can think of there are a lot of psychiatric disorders that have that. There are also a lot of neurodegenerative disorders that have that. So Alzheimer's disease has issues of apathy, so does Parkinson's disease and also impulsivity. So these are all potential targets for a adrenergic agent, the beta-2 adrenergic agent. The other advantage of using this approach is that it is a direct agonist. So if you think about the way that say you're developing antidepressant, SSRIs, neurodegenerative reuptake inhibitors, those are all indirect agonists. And by that, I mean that the mechanism of action requires there to be endogenous levels of whatever neurotransmitter you're stimulating.
Right.
So for SSRIs, you have to have serotonin available. If you don't have serotonin available, inhibiting the reuptake pump does nothing because you don't have endogenous levels. Same thing with acetylcholinesterase inhibitors, which were developed for Alzheimer's disease back in the 90s. Things like donepezil. Again, they work. They require endogenous levels of the neurotransmitter to be present. Same thing with neuroadrenergic reuptake inhibitors. If you don't have endogenous levels of noradrenaline, it's not going to be effective. We bypass that by going directly to the downstream postsynaptic receptors. So you don't need endogenous levels.
So can I ask, is the experience, like the individual experience of this, that I am constantly on edge?
Yeah, that's a good question. No, it's really not related to anxiety. What it does is it improves your ability to remember facts. It just gives a little bit more valence to the facts because you are stimulating the adrenergic system. So we have conducted, when we first started when I started Cures in 2018, we were still trying to figure out which receptor system would be the most beneficial to simulate. It made a lot of sense that it would be the beta-2 dependent because of preclinical work. So one of the co-founders of CuraSen is Mehrdad Shamloo, who's a professor in neurobiology at Stanford, and he's done a lot of preclinical work in which he's demonstrated both beta-1 and beta-2 agonists work very well in neurodegenerative disorders models in rodents. So there are a lot of models that you can use in rodent species in which you can look at the effects of different medications and see if they have an effect. So he's demonstrated extensively that these medications targeting both beta-1 and beta-2 are very efficacious. But in humans, actually, beta-2 makes more sense Beta 1 is more of a cardiac. If you have a beta 1 agonist, you're going to impact the heart. If you have a beta 2 agonist, you're not. And so we wanted a beta 2 agonist. It's also the expression in the brain is in those areas of the brain that are really relevant for memory, attention. And so it made a lot of sense to try that. So in our signal seeking studies, we tested that in healthy subjects. We tested it with commercially available agents. So we looked at salbutamol, which is beta 2 agonist. We looked at clenbuterol, which is beta 2 agonist. We looked at pindolol, which is a combined beta 1 agonist, beta 2 antagonist. And we looked at one other agent. And together we really were able to demonstrate both their ability to get in the brain, their ability to have an effect in healthy subjects by doing cognitive testing. So we looked at cognition. This was the work that we conducted at the Center for Human Drug Research at Leiden in the Netherlands, which is one of the premier centers in the world for this type of research. And they have a computerized battery, which has a lot of cognitive testing. Now, we demonstrated that if you give these subjects salbutamol or clenbuterol, they do very well. They remember more words in a word list than if you give them placebo. And if you give them a pindolol, which is a beta 1 agonist, but also beta blocker, they actually have an impairment in remembering, which is really the opposite pharmacology and also the opposite clinical effect. So these were studies we did in healthy subjects. We also did a arterial spin labeling, which is an imaging technique which allows you to look at cerebral blood flow. So it is a technique in which you would basically magnetize the blood at the level of the neck, and then you follow its progress into the brain so that you can have a measure of how much whatever drug you're looking at is affecting cerebral blood flow. What we demonstrated is that beta 2 agonist, all the beta 2 agonists we tested, the commercially available ones, plus our new chemical agent, were able to increase cerebral blood flow. Now, that by itself is actually a very positive finding because it's been extensively correlated that if you have an improvement in cerebral blood flow, you have better cognition, and that there's a correlation between a decrease in cerebral blood flow and neurodegenerative disorders. So if you look at patients with Alzheimer's disease and you look at them longitudinally, you'll find that their cerebral blood flow is diminishing over time.
I'm so glad you're starting to get into this because I think one of the topics that I wanted to talk about was the difference between disease modification and kind of symptomatic approaches. At least in the kind of first half of this discussion, it sounded to me like we were talking mostly about symptomatic kind of treatments, or again, memory, and in particular, maybe encoding memory, like while taking one of these agents. How do you think about like the kind of difference between the opportunity here to modify progression or modify the neurodegeneration versus just treating kind of symptoms?
Yeah, that's a big topic, I think, of discussion in general.
Yeah.
I think you'll see different points of view on this.
I had different points of view on this on the podcast.
Yeah. I think symptomatic treatment is very important. I think patients, what they want is, let's talk about Alzheimer's disease and just narrow it down to that to begin with. Patients with Alzheimer's disease have a variety of neurological and neuropsychiatric disorders. So they have memory as kind of a neurological deficit, but they also have apathy and depression, and agitation is kind of neuropsychiatric disorder. If you have a drug that actually treats these, even though it's not quote unquote disease modifying, it's something that would be beneficial to patients. And it's something that I think is not trivial. If you're able to allow these patients to be independent for a long period of time, you avoid them going into assisted living, skilled nursing facilities, and situations like that, I think is a very positive. There's a lot of energy being spent and money being spent on the development of anti-amyloid therapy.
Right.
So the amyloid hypothesis is probably 30, 40 years old.
Yeah.
By now, there have been several hundred trials looking at anti-amyloid therapy. And, the hypothesis for the involvement of amyloid, a lot of it is both on biochemistry, but also on genetic grounds, that there are genetic mutations in the processing of a beta, and that is correlated with early onset of familial Alzheimer's disease. So familial Alzheimer's disease is a small subset of the sporadic. So if you look at the AD in general, about less than about 10% familial, but 90+% are going to be non-familial. So it'll be late onset Alzheimer's disease. People get it past 65, 70 or so, as opposed to the familial AD, in which you see patients getting the disorder in the 30s and the 40s. So there's a lot of genetic data with the involvement of the amyloid pathway, if you will. So when I was at Roche back in 2008, 2009, and I was in Basel for 3 years at Roche headquarters, and one of the programs I worked on was gantenerumab, which is one of the early monoclonal antibodies developed for amyloid therapies. So I was very involved in that. I was very much a believer that the amyloid hypothesis made a lot of sense, that the reason a lot of these drugs had worked is because we were going too late in the disease, when people already had basically their brains had already been severely affected by years of having Alzheimer's disease. So what needed to be done is to go earlier in the process with anti-amyloid therapy, and that would be a much better situation. But, it has been tried now to go even earlier, is going into familial AD, to go into MCI, prodromal space. And we still don't see a lot of efficacy. I mean, probably the most recent ones have been lecanemab and donanemab.
Sure, yeah.
Both are approved by the FDA. And these are amyloid therapies. They're monoclonal antibodies that target amyloid, so they remove amyloid plaques. If you look at the biomarker, you see that either by using CSF or blood, or imaging using PET imaging of amyloid, you see that these drugs are extremely effective in the removal of plaques and removal of amyloid. But their cognitive impact is limited. So you look at so there's this concept of minimally clinically important difference, MCID. Is basically defined as what is the smallest difference you can have in the clinical setting that will be relevant to the patient, so that the patient will notice, I'm doing much better than I was before I took this drug. So MCID. In the space, in the primary endpoint that lecanemab used, which was a CDR sum of boxes, the minimally clinically important difference is about 0.5 to 1 point in the CDR sum of boxes. What they got in their studies was slightly less than 0.5. So it's really a very tiny effect. It's actually not even as good as Aricept, which was a cholinesterase inhibitor, small drug that was developed 30 plus years ago. So if you look at the biomarker data, it's impressive. Get rid of amyloid. If you look at the cognition data, it's not impressive. It's really not giving you that much of an effect. So there's discussion that what we're looking at with anti-amyloid therapy is disease modification therapy. I don't believe that.
Right.
I don't think we're seeing disease modification. And you have these patients on for 18 months before you really begin to see that difference.
Yeah.
So it would be wonderful to have disease modifying therapy. I don't think we have it with amyloid. With our mechanism of action of targeting the adrenergic system, it's very fast onset, so you can see symptomatic therapy early on. But there's also a very strong rationale for why you might see disease modification, because it has a positive effect on inflammation. It has a positive effect on autophagy, which are all components that are relevant to disease modification. So our hypothesis is that if we were to treat patients for a longer period of time than we've been able to treat them so far, we begin to see these disease-modifying effects and biomarkers and such. So far, the trials we've conducted have been short, the 2-week duration trials, in which we've seen cognitive effects, and also we've seen effects on mood using a biomarker for antidepressant effect. So antidepressants, one hypothesis for how antidepressants work is the emotional processing hypothesis, which it is to posit you're depressed because you have a negative emotional bias. In other words, when you look at the world, you interpret things that you and I would interpret as neutral or happy, you interpret it as sad.
Yeah.
And that is captured really nicely in a test called the facial expression recognition test. This comes from work from Catherine Harmer at Oxford, and she's been developing this for the last 20 years or so. So there's a lot of data showing that the facial expression recognition task is actually predictive of antidepressant response. Because the hypothesis is if you are able to change the negative emotional bias, that occurs early on in the antidepressant treatment, and that has to happen before you actually get relief from depression. First, you have to change the way you process the world, and once you've done that, you can get better.
Yeah.
And that comes on about 2 weeks, 1 to 2 weeks after treatment. And then that we captured in our study, looking at happy faces. So if you look at
Interesting.
if you show a depressed patient a happy face, they'll have trouble distinguishing that as a happy face.
Right.
You and I would look at it and say, oh, yeah, that's a happy face. No. With about a 70% recognition rate.
Yeah.
A patient who's depressed will score about 40%, which is what we saw in our trial.
Yeah.
And then when we gave them medication, it actually returned them to essentially normality.
Interesting. Maybe to be devil's advocate or difficult here, this kind of this use of the facial
expression recognition,
facial expression recognition test feels like it could be a similar trap to the amyloid test, in that it seems to be a potential like downstream biomarker. And why not look at maybe something more classic like a MADRS or a MD, for example?
Sure. No, that's exactly right, in the sense that if we were to conduct a longer trial, that's exactly the primary endpoint.
Okay, gotcha.
We would look at
the
beauty of the FERT, and
the FERT.
It's FERT. Yes. So you have to be careful how you pronounce it. The FERT. The beauty of the FERT is that it comes on very quickly, because that's one of the changes you see early on in antidepressant treatment. And our trial was only 2 weeks long. It's a crossover trial, so we had the power of looking at subjects as their own controls, because they were both inactive and placebo.
Sure.
So we showed positive effects on cognition and positive effects on this emotional processing, which is indicative of an antidepressant response. So what we would really like to do is conduct a trial that's at least 6 to 8 weeks long, in which we have the MADRS as the primary endpoint, using a beta 2 agonist with Nadal.
And is this was this for Alzheimer's patients with depression, or was it just for depression patients? I think I might have missed the set.
Yeah, you missed it because I didn't explain it.
Oh, okay, sure.
Yeah, so we conducted 2 phase 2 trials in patients, and both have been very similar. In it's been a mixture of Alzheimer's disease patients and Parkinson's disease patients.
Okay, sure.
The data we have with the FERT is in Parkinson's disease patients with mild cognitive impairment, so that they have a certain degree of cognitive impairment. And we also recruited initially patients with a small degree of depression.
Sure.
Using the HADS, which is the Hospital Anxiety Depression Scale, as a means of enriching the population for people who have slight levels of depression. Turns out in Parkinson's disease, depression is pretty common. 30 to 40% of people have some level of depression, as you might imagine. So that was the context in which we conducted that trial, and that was with the beta 2 agonist albuterol with Nadal. We also conducted a separate trial with our new chemical entity, which we call CST 2032, combined with Nadal. That also showed efficacy in a cognitive endpoint, which was the digital symbol substitution task. which is a really nice cognitive endpoint because it's widely validated and very sensitive. It looks at executive function, working memory, processing speed, and the complex attention, all in one test.
Yeah.
So,
Yeah. And are you, this is way beyond me at this point, but are you looking at depression in Parkinson's as its own indication, or is this a tee up for a more generalizable antidepressant kind of pathway, and then maybe even like similarly for cognitive impairment? Curious how you think about that.
sure. I think this gets back to a previous question you had is how do you come up with indications or what are the elements that are associated?
Yeah.
And that's not an easy question to answer because it has a lot of different inputs. I mean, earlier I was talking about the patient input, what do patients want? What's the unmet medical need? But you add to that also an acronym I like, even though acronyms confuse people if they're not familiar with it. Also, but PTRX. PTRS is an acronym that we use widely at Amgen. It stands for Probability of Technical and Regulatory Success.
Mm.
So that encompasses the technical aspects of it. As far as everything that goes into making the compound, making it a compound that gets in the brain, having something that has efficacy and for the right indication. But the regulatory part is also very important.
Mm-hmm.
Is one of the things we as far as challenges is in these arenas. For example, if we were very interested based on the data we had from the phase 2 trial, in which demonstrated positive cognitive effects in a Parkinson's disease MCI population. We thought, well, this is an unmet medical need. There's clearly a need for some sort of treatment in Parkinson's disease MCI. There's no treatment that's approved right now for the MCI population in Parkinson's disease. There's for the dementia population, not for the MCI. So we were very interested in developing our beta-2 agonist, clenbuterol and nadolol combination for PDMCI.
Mm-hmm.
But then you struggle with what is the primary endpoint. It's something you have to demonstrate in your phase 3 trials as that you've met your primary endpoint.
Mm-hmm.
But first, you have to agree with the regulatory agency what that primary endpoint.
Fair.
So if there's no real agreement, because there are a lot of different cognitive tests that could be used, then it becomes a little bit more challenging. So the regulatory success is diminished. In contradistinction to that, another project we're working on is on the other receptor for the adrenergic system that's very relevant, which is alpha-1 adrenergic receptor. So there are compounds that are currently available that target this receptor, and it's for two different indications. One is for people who have basically it's mainly men who have benign prostatic hypertrophy, not only men, that their urine doesn't come out very easily because of the BPH. And so they take things like Flomax, which is an alpha-1 antagonist. It relaxes the muscles and allows you the stream to do that. The other indication is neurogenic orthostatic hypotension. So this is a disorder which is prevalent in Parkinson's disease and related diseases like multiple system atrophy, pure autonomic failure, dementia with Lewy bodies. It's a phenomenon in which people stand up and they don't get enough blood flow to the brain. So when you and I stand up, our adrenergic system constricts our veins in everywhere, but particularly what's relevant is lower extremities, because when you stand up, blood will pool in your lower extremities unless you constrict your vessels. And when you constrict your vessel, you allow more blood to return to the heart. If you don't do that, it'll go to your extremities, pool in your feet, and you'll faint. And that's what happens. So if you have an alpha-1 agonist, it constricts those blood vessels. So there's a compound medication known as Modification, which is currently available with patients with NIH, but it's not a non-selective alpha-1 agonist. We are developing and have developed a compound which we call CST 3056, which we are currently starting at phase 2 trial on, looking at patients who have neurogenic orthostatic hypotension. In other words, when they stand up, their blood pressure falls.
Yeah.
And this drug, because it is selective, it mainly hits the venous system. So you get the desired venous constriction, you get more blood coming back to the heart and more cardiac output and more blood to the brain without causing the peripheral resistance that midodrine would cause, because midodrine also targets the arterial side. So that causes an increase in peripheral resistance. And that can cause an adverse event known as supine systolic hypertension. So when these people lie down, their systolic blood pressure goes up. And there's actually black box warning for midodrine because of that. There's a related compound droxidopa, which is basically an RB precursor, that also has the same black box warning. So that's a compound we're developing. And I mentioned that because, to your question, how do you choose indications? Well, it's an unmet medical need. The currently available therapies had this black box warning. They're not selective. Their pharmacokinetics is such that they have to be taken 3 times a day, which is cumbersome, especially if you're on a lot of other medications. And the registrational endpoint is very clear and is very straightforward. We've had interactions with the FDA already to discuss this program. And so we have agreement already on the regulatory aspects. So when we discuss this with, say, additional investors, and they look at our portfolio and say, well, we could see you doing a study where all your registrational endpoints are agreed upon. You've already talked to the FDA, and then you have another one, which is Parkinson's disease MCI, where there's really less clarity on the registrational endpoint. That PTRS assessment is lower because of that regulatory component. And so that's one part of the puzzle of how you come up with indications and how you focus on differentiation. But of course, at the heart of it is, what does your drug do?
Yeah.
Where is the efficacy of your drug? What is the mechanism of action of your drug?
Right.
And that really guides you in targeting the medication.
Maybe this is a naive question, but just given my current understanding of the MOA here, it sounds like you would have to be taking this pretty consistently, almost daily, and it would be a pretty quick effect, but also pretty quick kind of reduction, I guess, in effect if you weren't taking it. Is that a reasonable understanding of how the MOA would work here?
Yes, most likely. Well, let me start with the Alpha-1 program,
Sure, yeah.
because that's easier to understand. It's easier in a sense I always thought of the plumbing is easier to understand the circuits.
Yeah.
Because here is basic constriction of blood vessels and such. So it's been shown in the literature with midodrine, for example, is a good example. The midodrine half-life, the pharmacokinetics of the midodrine, if you follow that, it follows pretty much the efficacy of the compound. So once it's out of your system, it's no longer constricting your blood vessels, it no longer has efficacy. So you have to take it on a daily basis to have effect on the cardiovascular system. Mm-hmm. We expect the same thing for our compound, even though it is selective for alpha-1A, but what that allows is probably a better profile as far as not having that supine systolic hypertension, but you'll still have the effect will be dependent on you constricting those blood vessels, and that effect is dependent on exposure. So it's a pharmacokinetic phenomenon. So it's that there's this whole concept PK/PD modeling.
Yeah,
is basically you look at the pharmacokinetics. Where do you have exposure, how much exposure you need, and how do you couple efficacy to that exposure? Well, in the field of the alpha-1 agonism and vasoconstriction, it is very clear that you can make very beautiful models. You have a certain amount of exposure. As long as you have that exposure, you'll have vasoconstriction and you'll have your efficacy. Once you remove that, you will not have that anymore. For the beta-2 agonism, that's a little bit more interesting because if I can get back to a previous discussion we had, which was on the FERT, the facial expression recognition test, we did this study. I think I mentioned it was a 2-week crossover design. So we had patients either started an active or placebo, and then cross over to placebo or active. So we had subjects that we could use as their own control, and we could also see if you started an active in treatment period 1, what happened in treatment period 2. So if you look at the FERT data, those people that are started active in treatment period 1, when they transitioned to treatment period 2, their placebo baseline was elevated. And that was statistically significant. So what that means is there was a carryover effect.
Right. Yeah.
So carryover effects can either be good or bad if you're doing a trial, because it just makes your data interpretation a little bit more complicated. But it also can be good in the sense that you've shown an effect that actually outlasts the exposure of the drug. Because we measured the drug prior to the start of treatment period 2. There was no clenbuterol present. So the drug was totally gone out of the system. But the effect was still there. So there's something about the emotional processing and the impact of the drug that the beta-2 agonist had in the brain, as far as synapses, such that the effect was maintained despite the fact we had about a 2-week washout between treatment period 1 and treatment period 2. So I think there will be some effect that will be retained even after you stop the drug for a little bit, but eventually you'll have to start your drug again. The thing about clenbuterol is that it's a very long-acting drug. It's about a 35-hour half-life. So it'll remain in the system for a period of time.
Sure. Yeah. So we've spoken a little bit about the MOA. We've spoken a little bit about the FERT. We've spoken a little bit about a potential different approach to treating neurodegenerative conditions. I'm curious, as you kind of take a step back, I guess, on the last 7 years, and you look at the landscape of where things are right now, where the amyloid hypothesis sits, where let's call it maybe next gen biomarkers are. What is most exciting for you in terms of the future of neuroscience development?
Well, I think there are a variety of different mechanisms of actions that are being tried on. I think what's catching people's interest nowadays is psychedelics.
Right.
The treatment of different indications using psychedelics, psilocybin derivatives. And if you read the literature of what has been published over the last couple of years, you see it's been a little bit of a mix. Lately, we've had tremendous success has been published on depression. Where treatment is, again, to your point, do you need to have treatment every day? Well, it seems like for psychedelic drugs, that's not the case. You can treat once, and if the effect will last for a period of time. I think one of the challenges with psychedelics is a lot of them. There's this discussion, and I don't think has been resolved, which is do you actually need a psychedelic effect, or can you have efficacy without a psychedelic effect? And by psychedelic effect, if you think about things like hallucinogenic drugs, of course, these are acting through the 5-HT2A receptor.
Yeah.
Some of them cause these experiences or trips, if you will, that are highly meaningful, have a lot of valence to patients. And so it's been thought that that's very important for the treatment effect, and that's why you don't need that much, a daily treatment associated with it. But it also means that you have to dose these medications with trained professionals who guide the experience. And so one of the challenges there is that the FDA doesn't regulate psychotherapy.
Right.
So these trials are a combination of psychotherapy with a medication. And
they all say that they're not psychotherapy.
Yes, right. It is support. Well, it is. I mean, I'll digress because this is an important point, but there's a huge placebo response rate in psychiatry. So if you look at psychiatry trials, depression trials in particular are well known to have a very large placebo response rate. And part of that is because there is psychotherapy being conducted, the supportive psychotherapy.
Yeah.
You have somebody who's depressed, who's sitting home alone, suddenly becomes part of the clinical trial where they go to site and people care about how they're doing, care how they're feeling, ask and specific questions of how they're doing.
So checking in.
Yes.
Yeah.
So the comparison is not really drug versus placebo. It's drug plus supportive psychotherapy compared to placebo plus supportive psychotherapy.
Right. Yeah.
And the two are not necessarily additive to one another. So,
Right. Yeah.
so it's really, at the end of the day, as a drug versus supportive psychotherapy. Supportive psychotherapy is actually quite helpful for people who have been neglected.
Yeah.
So that's really an important component. So yes, in these psychedelic trials, they are getting psychotherapy.
Yeah.
It's so, but I think the proof will be in the pudding, because there are companies now that are trying to develop agents that still have the same mechanism of action, by acting through the same receptor system, but don't give you that psychedelic experience.
Yeah, it's kind of funny. You mentioned the psychedelic side. We've had most of the kind of classic psychedelic teams on the podcast, as well as recently had the team over from Delix on as well. He has nobody working on a non-hallucinogenic neuroplastogen and doesn't want to call it a psychedelic at all.
Right.
Just given it has no hallucinogenic effects.
Yes.
I think we're all eagerly awaiting to see some of these cards turn over. For sure.
Yeah. No, so I think that's something that's really exciting. Another area that I'm interested in, and I have been interested for many years, is digital health technologies.
Sure.
So I was when I was at Amgen, I was in charge of incorporating digital health technologies into our wider group, which was the medical sciences group, which is in charge of all the early development, with the idea of how do we leverage these technologies? Because when you conduct a clinical trial, in neurodegeneration, these will be 3-month long, 6-month long trials, right? And you see them maybe twice a month, but you don't know what's happening at home, right? Now, if you had a digital wearable device, some kind of digital health technology that you could actually measure what's happening at home, as opposed to when they come in for their checkup, their assessment, you just have so much more information, and you have information in the wild, so to speak, and where they're really, their home environment, which is much less artificial than a clinic setting. You have to draw to major research laboratories somewhere, and so I think there's a lot of potential there. It's been there's certainly a lot of activities. I'm in the editorial board of Digital Biomarkers, which we publish a lot of the work that's being done, and so I get to read a lot of papers. And what I see happening is a lot of smaller groups are trying to do the same thing and develop digital health technologies for a given subset of indication, but it's the same technology as somebody else is developing for slightly different indications. So what I wish there would be more harmony and larger consortia that are developing. This is your sleep wearable, this is your activity wearable, this is your 6-minute walk test wearable, and so on and so forth.
Sure.
Get them FDA approved, become the gold standard, and you can use them as primary endpoint.
Yeah.
Because there's a lot of value in that. And in psychiatry, it's interesting because you can also leverage smartphones and how much contact you're having, how much you're participating, texting, phone calls, etc.
Yeah. So we've covered a lot right today.
Yes.
Right. Translational medicine, like the adrenergic system, its applications in kind of disease modification, but then also in symptomatic treatments. I've really enjoyed the conversation around psychedelics and digital biomarkers. I'm curious, as you look back on your career, have there been one or two kind of like key moments, discoveries, patients, breakthroughs that have really affirmed the kind of path to come on and work on psychiatry, work on neurology?
Yes, so for sure. I think that my focus, it's people that go into PhD programs go into with the thought that they'll be in academia and they'll be an academic exercise, and and be the what's called the triple threat, right? To do clinical work, do research, and do teaching.
Right.
And that's what I was tracking myself to be. But then when I was recruited in industry, I was a very junior faculty at the time. And I realized one thing I didn't like was publishing and the whole process of publishing a paper.
Yeah.
And since so much in academia depends on you publishing papers, it's like I realized, well, I think this may not be the best fit for it. And I was open to the idea of industry. I was interested in the idea of translational medicine, and but more importantly, having the thought that you have the potential to impact millions of people if you come across a medication that's helpful and has meets an unmet medical need. So I was lucky enough when I joined Amgen to become the early development lead for what was then called AMG 334, which was a monoclonal antibody that was being developed for migraine. In a target the calcitonin gene-related peptide, CGRP, which had been implicated in migraine. And Merck had developed a small molecule targeting CGRP and had shown success, but then they came across liver tox that was not related to the mechanism of action. It just was an off-target effect. So they stopped that. So the field was open. Amgen is a specialist in antibodies, not small molecules. So they went after an antibody. With the idea that you would develop a prophylactic agent, you would do subcutaneous injection once a month. It would block the CGRP receptor from the ligand binding to it, and that would prevent migraines. And so I led the early development of that compound that became known as Arenalimab, and then it was approved by the FDA in 2018. I did the FIH study in 2012. We submitted in 2017. That was approved in 2018. So that was really a very nice moment for me to see that a drug that had a very big impact in its development approved by the FDA. And more importantly, I read there was a New York Times front page article on amyloid right after it was approved, in which they talked to many of the migraine patients who were involved with studies. And so they had quotations from these patients like, "This drug changed my life."
Incredible.
I went from having, 12 migraines a month to having no migraines a month. It has changed my life totally. And then in the comments section, there were, hundreds of people just writing in about how migraine is such a factor in their lives and how this has potential change in their lives. So that was very rewarding. It reminded me of the conversation I had with Luca Santarelli, who was my boss at Roche and Basel. He's a senior VP and has become a serial entrepreneur. He's really a very smart guy. And I remember having a late night conversation with him about our work and our roles in industry. He said, "This is a privilege. It's a privilege to work on this because you have you're surrounded by very smart people, very dedicated people." And you have the potential to impact millions of patients.
I certainly sit in the other side of the table here. We are constantly reminded of the impact of the work that folks like you do. Just given the nature of the relationships we had building with the patients who sign up on our platform who are out there looking to understand what's available in research, and we're certainly grateful for all that important work, and we're excited to be able to support it along.
I think it's great.
Well, Gabriel, I've so enjoyed this conversation. Thanks so much for taking time. Is there anything that we haven't talked about that you're hoping to kind of address?
This has been a very wide and extensive discussion, I think. I think, bottom line, I'm very excited about our next study, which is a neurogenic orthostatic hypotension. I was very pleased to see it in your platform. We're trying to recruit for that study. It's for patients who have a drop in blood pressure when they stand up. We think our compound has tremendous potential there. And I'm very excited by it and looking forward to getting some patient data.
Yeah, absolutely. Well, we're excited to see where it goes.
Yeah, thank you so much.
All right, well, take care.